Wanted to give a very warm welcome. I'm the founder of GSF, and we celebrated last year, as many of you might know, 25 years of this work. It's come a long way, expanded, and now I'm chair of GSF, and I'm absolutely delighted to welcome over 100 of you from all over the country, particularly looking at population-based end-of-life care and how we can address the needs of our population. And with that in mind, particularly delighted to invite Professor Samir Gray, who I've been working with, I don't know, from almost 20 years. I'm so impressed with his big view and his approach to this issue. We worked quite hard together with Right Care and with RCGP and end-of-life care metrics some years ago and published a paper, I think he's going to mention at BJGP. And also Joe Bowen from Dudley Hospital, who's a fantastic speaker about the wonderful work that they're doing at Dudley Hospital and how that is spreading around. So two wonderful external speakers invited, and also Julie Barker, our Associate Medical Director, who's chairing this event. Next slide, Anne-Marie. And just in passing, as I'm chair of this new coalition of frontline care for people nearing the end of life, which is uniting a large number of the major health and social care organisations to work together to lobby government and to try and enact good care delivered by generalist frontline staff. So there's a lot more that I can say about that. If you want to know more about the coalition, let me know. But one of the things we've been asked to do is to support this new Palliative End-of-Life Care Award. The deadline is very soon, a couple of weeks away. That's the website there. And we suggested it would be a good moment. It's mainly social care awards, but we suggested there should be two new awards: the Integrated Care Systems Award, looking at the way people support end-of-life care in their ICB or ICS, and the partnership working across health and social care. There are lots of other awards already there. You'll have a look on the website and see that. But I just mentioned it now in passing, but please do nominate good examples of practice, and let's get this showcasing of good practice and the importance of end-of-life care in our area higher up the agenda. And I'm very delighted to welcome so many of you. I know that there are over 100 from all different parts of the country, and there'll be follow-up afterwards. But now I'll hand you over to Julie Barker to take you through the programme. Over to you, Julie.
Hi, thanks, Kerry. So we hope that you'll be stimulated and inspired this morning. We've got lots of really interesting information to share with you. We hope to keep to time, but as Julie mentioned earlier, if there are pressing questions that we're still answering at the Q&A, those of you who want to stay on are welcome to do that until we finish all the panel questions at the end. So just thinking about what we're aiming to do today, we're really aiming to broaden our thinking from business as usual to how we can intelligently and effectively meet present and future needs of our population as they approach the end of our lives. Now these are the Mentimeter clouds that people are creating as we speak. There's lots of very positive words coming up on the screen about how people are feeling today, and do be completing the rest of the questions if you haven't already done that as we go through. The results will be popping up during the course of the morning. Next slide, please, Anne-Marie. So we've got some roles coming up. So we've got neck and neck clinicians and management at the moment. Quite a few in the other category. It would be interesting, those 5 of you have so far said you're in other, if you could put in the chat what your role is, that would be really helpful. It's just from the point of view of understanding our audience and helping you to the best we can. It's good to know exactly what kind of role you've got. I know when you registered, you would have given a little bit of information on that. Next slide, please, Anne-Marie. So how do we feel about our ability to improve end-of-life care in the area? It's just taking a few seconds to load up. That depending on your role, you may feel very empowered. Oh, we've got some great teams on the call. That's really good to see. And nobody so far says they have no influence, which is absolutely fantastic to see. And I hopefully that reflects that all the areas that you work in are very collaborative and work well with all members of health, social care, and that hopefully the third sector as well, and the community at large. And next slide, please. So I'm going to hand over now to Samur Gray that Kerry has already given a little bit of information about. When I was looking up Muir's background, he's one of the very few clinicians who have Wikipedia entries. British physician, I think one of the most forward-thinking doctors on the planet, personally. Been prescribing exercise for decades, way before it was a thing. Developed breast and cervical screening, for which he was knighted. Very versed in digital methods of sharing healthcare. Author of several books on aging well, and personally I've started one of them already. And currently director of the Oxford Value and Stewardship Programme. And for me, he amplifies one of David Bowie's positive quotes: aging is an extraordinary process where you gradually become the person you always should have been. So that's something that I'm aiming for going forwards. So over to you, Muir.
Thank you very much. And I'll share my screen. Are you going to do it? Okay.
Yeah.
So I'm going to say a little bit about what's happening in health and social care in general to set the scene. Because although we're focused on the last year of life, we need to understand what is happening and, in my view, what should happen. So what we see if we look ahead is that need and demand are increasing faster than resources. And the key resource is not money. The key resource is staff. But there's also the issue of carbon, moving to zero carbon healthcare. And actually, many clinicians are more motivated when you discuss carbon than when you discuss the NHS finances. Next, please. So why are need and demand increasing? And I'm setting the context here for the end of life. And there are 4 factors taking place. Next, please. Population aging is usually blamed, but it's not actually the major factor. And we know that we can reduce need and demand for health and social care. And the other part of my life is called Living Longer Better, about how we help people compress morbidity at the end of life. And that's what people want. An increase in health span, not an increase in lifespan. And sadly, for the first time in my career, healthier life expectancy has been decreasing. And the social class gap between the most and the least deprived has been increasing. So population aging we need to take seriously, and we need to have a program to help people live longer, better. But there are 3 other things taking place. Next, please. The first of these is the invention of new conditions and diseases. Now, some are really important and real conditions like COVID. But here's an email I got based on a single reading of hemoglobin A1C of 43. And I was invited to go in and see the practice nurse who showed me the Saga food guide. And my friend, who's thin as a rake, aged 80, got a phone call from her GP about prediabetes. I mean, a phone call from your GP, can you imagine it? For a condition I don't think exists. It's just we've made it up. But it's generating a huge amount of work. It's prediabetes could be classified as walking deficiency syndrome, in my view. Walking deficiency and calorie excess syndrome. Next, please. And here's another even more interesting non-disease that I've got called MGUS. Now look at that sentence there, starting the results. Very minor abnormality, which was too small to quantify. Your light chain ratio is also mildly out with the normal range. These abnormalities are very subtle. Well, you're on a high road to a bone marrow when you start getting into this, this care pathway. So we need to be much more conscious. Next, please. And then there's new technology. So I did not approve screening for glaucoma when I ran the screening programs. But now every optometrist has got one of these little machines. And eye departments are being overwhelmed with people referred with minor increase in intraocular pressure. Now, new interventions have been fantastic. Hip replacement, chemotherapy, MRI, but they have had an impact on the health service that hasn't added value. Next, please. And then the fourth factor was described very interestingly by David Eddy in the 1990s as the relentless increase in the volume and intensity of clinical practice. So these are the things that are taking place. Next, please. So what are we going to do? Well, we've got to carry on doing the things we've been doing, evidence-based decision-making, quality improvement, and the like. But we've missed three big problems here. Next, please. And the first is called unwanted variation. That's variation in healthcare services that cannot be explained by variation in need or by specific preferences of the patients or the populations involved. This was created by a man called Jack Venberg, a wonderful person who died 2 weeks ago. Next, please. And if you look at this in the NHS, here's just a couple we could put in the NHS Atlas of Variation. The rate of anterior cruciate ligament repair on the left and spend and MSK on the right. And no one had any clue where they were on this distribution curve. And we can start to think now about doing, and I think Kerry can tell us about the variation in the percentage of people dying at home, for example. Next, please. We'll discuss this in more detail. To say Kerry will comment on this, I'm sure, but here's the percentage of deaths that occur in hospital by local authority. This is go back 10 years, but I shouldn't imagine the variation has changed in any way. This is unwanted and unrecognized variation, which shows two other problems. Next, please. The first of these is overuse of healthcare. And when we're all thinking about the underuse of healthcare, overuse is an issue. Because you see, as you put more money into healthcare, into MRI, for example, or antidepressants, or chemotherapy, the benefits go up very sharply, but then they flatten off. It's called the law of diminishing returns. Next, please. Now, unfortunately, all healthcare does harm. All healthcare. High quality healthcare does less harm and more benefit, but the shape of these two curves is the same because we're giving people radiation and chemicals and operations. And what Avarius Donabadian did was to subtract harm from benefit. Next, please. And he produced this wonderful graph, and this was 1980, the point of optimality. And if I were speaking in Bradford Town Hall or wherever, I'd be asking the public, where have we gone beyond the point of optimality? And when I've done this, obviously things come up like prescribing, imaging, and admissions in the last year of life would come up. And this is a waste of resources, because waste is not just what we put in the bin, it's what use of resources we give more value if used for another intervention or for another group in the population. Next, please. And here is, sorry, go back one. Here it is unadorned. This is the most important picture in healthcare. And I think we're circulating the PowerPoint. So use this. Yes, Christina, on you go. Take this picture, and this is the most important picture in healthcare, in health centers, hospitals, and town halls. Use it. Okay, next, please. The other problem revealed by unwanted variation is the underuse of healthcare combined with inequity. And here's a study done, and it's been repeated, showing that the least deprived people in the population get more joint replacement than the most deprived. And this doesn't take into account insurance-based joint replacement. So inequity. And the same you need to think about in end-of-life care. Using person's postcode is the best indicator of deprivation. Next, please. So here's what we're talking about. Value, you'll hear this word. So there's personal value, allocative value, how much do we spend on the last year of life, or how much do we spend on cancer or on respiratory? And the health service at the moment hasn't a clue. The Director of Finance I met couldn't tell me at the nearest 40 million what they spent on respiratory disease or end-of-life care. They could tell me at the nearest pound what they spent on health centres and foundation trusts, but not to the nearest 40 million what they spent on lung disease or heart disease. And then this issue of value here, which is much more than efficiency, technical value. And that's taking into account the impact on the population, not just on the patient seen. So that means we don't just measure efficiency, we measure equity as well. And number of days in hospital in the last year of life, or number of admissions, would be well, the sort of criteria you would use to measure the value of a service. Okay, next, please. As I say, we're now thinking much more about waste. Not just inefficient healthcare, but waste when intervention doesn't achieve outcomes that matter or do more harm than good. The last two people I know who had a cataract operation, when I said, what difference did it make? They said, oh, not much. Now, I'm sure they had cataract, they had a high quality operation, but we hadn't really found out what was bothering them. And did the operation, which can go wrong, was it really justified? Was it high value? And then waste is due to opportunity costs. Next, please. So, someone like me, who doesn't know a great deal about end of life and the last year of life, I was very into read articles like this. Oh, more investment in palliative care. But actually, this didn't cost any more money, and it may even have reduced cost. So people who got palliative care compared with people who got usual care, they lived longer. And the investment in palliative care did not add to healthcare costs, and I'm sure reduced healthcare costs. Next, please. Here's another very important article about respiratory disease. And this is starting to think now not about COPD and asthma, but about breathlessness and a breathlessness support service. And again, here, this had a big impact on people with breathlessness in the last year of life. This is from Irene Higginson and the team at King's. So more is not always better, but better doesn't always cost more. And we need to start thinking now, supposing we could develop a budget for the last year of life and give it to people like you. We start to pool together all the spend in primary care and cardiology and cancer services. Then we start to look at how we spend the money to best effect. Next, please. So in developing end-of-life care, or indeed care for any group, people with type 2 diabetes or people with back pain, there are 5 stages. I'm just going to quickly through, and I'm keeping my eye on the clock usually, so I'll finish on time. Next, please. Number 1, move from 2-dimensional healthcare to, next, please, 3D healthcare, and start developing budgets and real services based on segments of the population defined by need. And I would certainly see people in the last year of life at this sort of group we should be focusing on. Yes, you need primary, secondary care, tertiary care. You need bureaucracies, but core business is the population groups with a common need. Next, please. Secondly, Healthcare is so complex, it cannot be managed by either markets or bureaucracies. And this Oliver Williamson got the Nobel Prize for pointing this out. Next, please. So what do we mean by designing a system? So here, these are the stages, and there's lots of resource on this available. But I'm just going to speak about a couple, really. So the scope, I think last year of life is a good scope. Could be last 5 years or last month or whatever, but last year of life. The population, well, I'm quite a favor of this reorganization. I think it's my 20th. So it's probably the place-based partnership is the jargon, isn't it? Or the catchment population of the palliative care service or district general hospital, now with a number of primary care networks. But you've got to be clear which your population is. Now, next, please. What is the aim of the service? And this is the sort of aim that we might put forward. This is a short, simple statement. Next, please. Then we go on to setting objectives. And when I did this with type 2 diabetes, this was the set of objectives that people came up with. And I said, very good, 5 out of 10. Next, please. Now, if we were doing this for a population-based system, and then maybe time at the end to take suggestions, or maybe people could put in the chat one objective, and this would be national. Kerry and I believe in a development of a system, and we've got GSF has done great work in developing a system. But what are objectives? Objectives are key. Next, please. But when I said 5 out of 10, I meant they were a bit too clinical, the objectives for type 2 diabetes. Look at that bottom 5. And similarly, in an end of life, last year of life system, I'd see those bottom 5 as being essential. Mitigate the effects of inequity, promote research, educate all relevant professionals about what's going on. Next, please. Then the third stage is to ensure good decision-making, and that'll be covered later. So personalized value and population value are two sides of the one coin. Next, please. And then develop networks. This is the century of the system and the network. And those of you with a special interest need to start thinking in terms of networks, not hub and spoke, but networks. A network for people working to enable dying well, working on the last year of life. Next, please. And finally, we need to think of the culture of stewardship and not wasting resources, because if we waste resources, it's other patients who are deprived. Next, please. And just to finish with 2 references, this is one that I started with Kerry some time back, and this was excellent work done in Essex by the hospice and by the public health and primary care teams. And the references we'll put in the pack. And next, please. And this is a very good project just finished in NHS Highland, and same sort of issues about developing a system. So these are 2 freely available reports. I did, I think, oh, thank you very much. Yeah. So here's the editorial Kerry and I wrote. And the line actually should move a little bit, not from corner to corner, but diagonally across. But we do need to move now to a new understanding. From the understanding of palliative care is very important. We need a hospice, to the wonderful work being done at the moment by hospices to move from real estate to population. So enough from me, and I look forward to discussion. Maybe keep your eye on time, so we start a little bit late, but we can take questions at the end, I think.
Thanks so much, Muir. That's given us a lot to think about, and hopefully my presentation will build nicely on that for people. And we certainly will be answering questions at the end. So let me introduce myself to you. I have the privilege of having worked as Associate Medical Director with GSF for the last 6 months or so. We go back a long time though. Like most GPs, I'm a GP by background, just so that you're aware, 30 years plus and counting. We have GSF as the baseline for our end of life care. And it's not just our area. I think most primary care across the country still uses GSF as the foundation for their end of life care. And most GPs and care homes view end of life care as being a key part of their services to our population. With GSF, we've in Nottinghamshire, where I'm based, have been working as a cross-boundary integrated care site for a number of years. We've done some metrics work together, and I'm still clinical lead for Nottinghamshire ICS. Before that, CCGs, before that, PCTs, and it goes round. I've also worked in hospices and been a hospice trustee for many years. So I have a good understanding of the challenges that hospice care have, particularly independent hospices, but the such important partnering care that hospices, care homes, as well as our acute trusts and primary care and domiciliary care all contribute to the end of life care for our patients. So I'm hoping today to be looking at some imperatives and drivers for improving end of life care, how we use our data, what matters to our population, and how we can best help them achieve the best final phase of life care. Next slide, please, Anne-Marie. So what word currently are we saying is the priority given? So unsurprisingly, given the slides that we've seen so far, we've got lots of positive ones. So the big words are the most commonly submitted question results, and the small words are the less commonly submitted ones. There are some results saying not enough funding and negligible, but for many of you, the priorities are high. So that is really good. Let's move on to the next slide, please. So this is a snapshot from The Guardian, which reflects Chris Whitty, our government chief health officer, did an annual report which really reflects many of the things that Muir was talking about with regard to the fact that we need to look at quality of life rather than purely prolonging it. And as most of you guys will know, having conversations geared around what matters to people is critical to achieving this. Next slide, please. So our population currently not only is getting older, but living with more comorbidities, as we're all well aware. So quality may not be that great for many of our patients. And as we know, all of us who have elderly relatives, or maybe some of us in the audience, are already thinking, actually, if I get to 90 and everything's falling apart, do I really want to keep going forever? My gran from the age of 90 was saying, I just want to go now. I've lived a long life and a happy one. I don't want to keep going. Don't keep me going. The remit was very clear. Next slide, please. So this was an interesting one. This is from Chris Whitty's report. And I didn't know this until I looked at these two maps. But our population are migrating to the coast as they get older. So those of you in coastal areas have quite a big challenge on, I would say. Those of us in cities, we might be dealing with a lot of deprivation, but a lot of our population will not be in the city as they are dying. Having said that, it's certainly in Nottinghamshire, we've got a lot of people needing end-of-life care in the city centre, which is an area of inequality. Next slide, please. So some of you will have already put your pins on. This is where those who've entered their geography are. So the areas that are getting a lot of retirees are not that represented in here. So maybe our next conference will need to target them. Next slide, please. So this is one of the key areas in Chris Whitty's report. The headline being improving quality in life sometimes means less medicine, not more. In other words, a change of gear for our frail elderly, linking very much with Muir's points about sometimes we need to be doing less or less technical stuff, different things. So a question at the bottom of this slide: consider how your area is training your frontline staff in conversations designed to avoid overtreatment. Next slide, please. And click again. So 2 key reports here. NHS England's remit for ICSs to be commissioning palliative and end-of-life care. It was very much geared more towards specialist palliative care, but very much also saying we need to be looking at generalist end-of-life care as well. And I'll be referring to the King's Fund report in a minute. Next slide, please. Most or hopefully all of you will be familiar with the Ambitions Partnership and the report that it produced. The link for the Ambitions Self-Care Assessment Toolkit will be going into the chat. But one of the things that the NHS commissioning remit asks us to do is an Ambitions Self-Assessment Toolkit. We're in Nottinghamshire, we're just undertaking or coming to the end of our second round of ambitions. And it is an eye-opener, especially if you get good representation when you're doing your assessment. Next slide, please. This is the Marie Curie ICB survey, which looked at end-of-life care strategy and, in other words, how much ICBs know about their spend, where end-of-life care is in their strategies. Next slide, please. And can we flick on to the next one? So the responses, there was a good level of response to Marie Curie, and 77% of ICBs had done an Ambitions Toolkit assessment. Interestingly, I've ringed that 69% were much less clear about their equalities, their healthcare inequalities. And this will relate to what kind of data you're able to get. Next slide, please. So this Menti question was very much through an ICS lens. There's no right answer particularly, because they're all important, but those of us on this call are saying that it's our workforce that is the most important factor. And I'm delighted with that response. As you will know, GSF work with our workforce. And so the fact that you're with us today obviously reflects the fact that you have your key asset at the heart of where your attentions are lying. Next slide, please. So this slide is from Nottinghamshire, and it is the priority areas for our place geographies. So from our ambitions toolkit and our local data, we highlighted that our population were not being served well if you were frail, if you had dementia, if you were repeatedly in and out of hospital with falls. So consequently, those key groups have been highlighted in our local strategy as needing some extra attention. And we're actually just about to have a clinical senate on end-of-life care, looking particularly at these areas and how we can do things differently to manage and support them better. Next slide, please. And click again, Anne-Marie. That's brilliant. So this is the King's Fund report. Key findings there. You will see that they are recommending to commissioners that we understand better our patient, carer and community experiences, that we track needs and act on inequalities, that we include generalist and social care in our quality monitoring, and that we convene partners to collaborate on improvement. And hopefully you'll be doing that when you're developing your strategies and looking at ambitions work. Next slide, please. This is the end of life NHSE draft objectives, and you'll see that 24/7 models of care and health inequalities have both been highlighted as key areas that we need to be looking at. Next slide, please. And if we click through on the highlights, so the delivery plan highlights some key areas which I'm sure we've all got highlighted in our strategies. And at the centre of that is workforce. In our area, training and confidence, we've done a lot of work on recently. Next slide, please. So you'll recognise this slide from Muir's presentation. I've re-entered it just because I think it's really important just thinking about how we change our gear in our areas. In Nottinghamshire, we're doing quite well, I would say, on specifically on looking at picking up our non-cancer end-of-life patients. But we're still not good at some of the training elements and some of the other things which I'll be talking about in a minute. Next slide, please. So the Health Foundation have done a little bit of work on what matters to patients and their families, specifically on mental health issues. But there's actually very close association between what matters to patients with mental health and what matters to patients with end-of-life care. Next slide, please. So this is with a patient and carer lens. What are the most important factors? So we've got feeling supported, compassionate and open conversations, sharing what matters most at the top three. Again, these areas are key to a GSF approach to end-of-life care. The work that is done in care homes, in hospitals, in the primary care setting, domiciliary care, all emphasises these factors. Moving on to the next slide, please. Now, these bullet points were things that came up for me during an audit of end-of-life care that I've done. And obviously, you'll see that they tend to be a bit negative. There were lots of positives to find, but I'm emphasising the gaps here, thinking about health inequalities and what often goes missing. We're still missing opportunities for identification. We're still missing cues for advanced care planning, despite several presentations in primary care, in secondary care, in A&Es, people with recurrent falls, discharged medically fit for care, but nothing about what's causing the falls. Are they being over medicalized? Have they got too many medications? Information sharing, still patchy despite EPACs. Care coordination, an escalation response. The audit that I did recently shows that we're quite good at producing respect forms, but some of the key things that you might do in a crisis, who do you ring? Where do you go? Do you know the right person to contact if your GP's not open? That was often missing. So we need to get better at filling in our advanced care plans. This next one I've highlighted because it came up repeatedly in the audit. Strong patient-centric GP leadership positively affects care. So we're able to triangulate our end-of-life metrics with practices that have a high number of GP appointments and a high number of GPs. And there is a clear correlation between good end-of-life care and strong GP leadership. That is something that I think we need to be shouting about up the chain, because GPs are under the cosh at the moment, and a lot of GPs are either retiring or going abroad or burnt out and being replaced by people who are very compassionate, have a lot of training, but don't have the degree of expertise that our GPs have, and we're losing it. So for all my colleagues in ICSs around the country, have a think about how healthy your GP population is. The last one, patient outcomes. Well, I've talked about that, so let's move on to the next slide, please. These are some of the quotes from our patients and carers. Well, they're actually all carer quotes from the last 6 months, people who have died in Nottinghamshire in the last 6 months. I was privileged enough to get a lot of really valuable feedback from the carers of those people. There was a lot of very good positive feedback, and I've quoted some of those, but there was also some feedback that made me want to cry. Some of our social care, we know that our fast track providers don't really train people very well. We're actually doing something about that locally in Nottinghamshire. He was just left to die and nobody told us what was happening. This was someone who'd been in hospital for several weeks, not a hospital that have got GSF accreditation, I have to add. We do have some GSF accredited wards in Nottinghamshire, and this wasn't one of them. But yeah, so there's still a piece of work we can do, and I would encourage everyone to do after death analyses, do some audits on your advanced care plans, try and get to talk to people, because it will really give you some valuable intelligence. Next slide, please. I'm going to try and speed up a little bit. So a compassionate approach. The compassionate care movement is gradually spreading across the country. We're about to embark on it in Nottinghamshire. Sheffield are a few years ahead of us. Essex also have a compassionate community, very much based on values. This is how we increase our partnership with our communities. End of life care, as we all know, is not just about health and social care. It's about our communities and partnering with them. Next slide, please. You'll see a lot of GSF on this slide. Needs-based coding. Our care homes are using this really effectively. They're using it in their advanced health and care homes, home rounds. We've got the proactive identification guidance, which we use in Nottinghamshire as our key indicator to flag up those patients that we need to be having advanced care planning conversations with. Next slide, please. This is from the Fingertips Toolkit, which most of you will be familiar with. It was pulled off our OHID report for Nottinghamshire, which I'll be referring to very soon. It shows how well we've been doing using the GSF PIG in identification. And within those people who are being identified in Nottinghamshire, most of those are non-cancer patients, which we're all very proud of. Next slide, please. This is from our local dashboard. It's a very busy slide, which I'm not going to look at any detail. But I would encourage those of you who aren't yet collecting local data and presenting it in a way that you can share with your partners in care to consider doing so. It gives us real-time feedback on how we're doing. Next slide, please. Again, from our dashboard, this is looking at advanced care plans. Our different places are colour-coded, so it tells us how we're doing across our patch. Those in Bassetlaw are making great strides to catch up with the rest of the county, having joined us last year. It's really powerful for our partners in care to see this kind of information. Not least, we're all a little bit competitive, and that helps, I think. Next slide, please. Professionally competitive, I would add. This is information showing emergency admissions in the last 90 days for those who have died. And this is all patients, so it will include those who are not on our end of life register, but we can separate the two. And as you would expect, those who've been picked up and have advanced care plans and really good treatment escalation plans are much, much less likely to end up in an emergency situation in hospital. And we've demonstrated that really effectively, both in Nottinghamshire, and you'll also see that in Joe's presentation, which is coming on next. Next slide, please. So this is the OHID data pack and where you'll find it on NHS Futures. Next slide, please. And it highlights for you some of your health inequalities, or I should say demographic inequalities. So in our area, we have high levels of child deprivation, a lot of child carers. We have lots of indicators of multiple morbidity, and lots of people living alone. Next slide, please. And we'll flick through these. These are the packs that we've sent out to our different PCNs. Next slide, please, Anne-Marie. So some practical data and some practical advice on how to use the technology that's available to them. Some of our training feedback has indicated that quite often our frontline staff don't really know how to use the technology that makes it easy for them. Next slide, please. So just a brief reminder, we've all got a digital challenge in sharing our care plans. This has been escalated nationally. Unfortunately, there's no national plan to have a digital platform for us to share our advanced care plans. So everybody's doing their own thing. It really emphasizes the importance of briefing our patients and their families of the importance of self-declaration with regard to them having gold status and an advanced care plan, and waving it at people to get them to review it or look at it. Next slide, please. And we're coming into land now, but this is a slide which just demonstrates the effectiveness of patient identification, advanced care planning, good conversations, and good systems. It will help you move your resources back into the community and frontline staffing if we are getting the right people into hospital, not those who just don't want to end up on a bed getting deconditioned. Next slide, please. So on that subject, we do need to have brave conversations with our patients and their families. What really matters to them and how we help them achieve that often means doing less expensive stuff. Do we really need to refer you? What's going to happen if we do refer you? If you've got cancer, do you really want to start chemotherapy when you've got multiple morbidities? They're difficult conversations, but we need to be empowering our staff to have them. Next slide, please.
Julie,
we're done.
Julie, there's just one question in the chat box that's come up from Rakesh, just asking specifically, do you have a patient feedback template or something similar? Because you mentioned there about carers feedback, so just across your locality.
Right. Really good question. And the answer is we don't. That feedback I gave was based on phone calls with people, and we had an open conversation. But it is something that your patient experience team, if you've got one, might well have. We do have one in Nottinghamshire. If we have a template, I haven't seen it, but you prompted me, Rakesh, to ask that question.
Could I just add, Julie, that when we've talked about the work in Nottinghamshire with GSF, and we're talking with Joe in a second as well, there is the discussion about what kind of offer GSF might give for other ICSs, and we'll come back to that. Maybe you say a few words about that at the end in the Q&A. I wonder if I can move us on to Joe Bowen and to oh, sorry, you wanted to say a little bit about the Mentimeter next, did you, Julie? I just wondered because we're running a little bit late. And
yeah, no, it's fine. Go for it, Kerry. We're on for Joe.
Yeah, lovely. Well, lovely. So we're delighted to be welcoming Joe from Dudley Hospital, and who's done GSF across the whole hospital terrifically effectively, and particularly Julie Armstrong-Wilson, you were going to say something about how this is an example of GSF as a springboard for change. Julie, do you want to just?
Sorry, yeah. Well, I think actually Joe will be able to demonstrate how it has been a springboard for change. To be fair, rather than me actually say, I think it's always better to come from the organisations that have worked really hard over the years. And they did, you know, they've used GSF as that springboard for change, and it is yeah, it's just a huge testament to the work that they've done. I think being led in their local community by the Acute Trust, which is just, yeah, it's great. I get lost for words actually when I speak about the hospital, because I do feel actually what they've done, the change they've made, and the culture, the way they've changed the culture in the trust is a credit to Jo and her team actually leading the way there. So without further chat from me, really, I'll just introduce Jo Bowen. Jo, are you on the call if you want to come off mute?
Yes, I'm here.
There you go.
Hi. Thanks for that introduction, and thanks for the opportunity just to talk about the work that we've done at the Dudley Group NHS Foundation Trust at Russell Hall Hospital. Next slide, please. So I just want to give you an overview. So we'd done a lot of work prior to 2018, looking at different tools that we could use around end-of-life care, a lot of audit work, and what we were, and work with mortality teams within the trust. And what we identified was that we needed earlier identification, that coordination of care, earlier conversations, and that's when we decided to embark on the gold standards framework. And what we did initially was using some of the already published data around, and you can see in the top left-hand side there, around 30% of hospital patients are in the last year of life. We did a snapshot review across the trust in 2018 and showed a similar result. We got 34%, but what was useful is the wards could then, we broke it down by ward, and the wards could look at this and say, yeah, that fits with the evidence we've got around our mortality. Next slide, please. So when we started the whole hospital approach of the implementation of the gold standards framework, because of all that prior work we'd done, we had got quite a few palliative care champion nurses. We had covering every ward and department. We had fewer consultants, but because of the engagement we had with our exec team and medical director, we managed to get a name consultant as well for each ward and department. And when we did the workshops with the GSF team, everything was very much co-designed as a team. So the consultants, the nurses, we had every level really within the trust became involved with this to design what we were going to do. And with this, we obviously, Julie's already talked about the proactive indicator guidance and what was useful because the consultants were involved. They could review that and say, yes, we agree. And I know they put some suggestions forward with evidence back to Kerry as well. Then we designed care plans around the needs-based coding for GSF, green, amber and red. And obviously we already had some of the tools there for planning your future care, and we'd already developed a communication document for priorities for care. We'd also got a great tool we used, which is just an acronym that we developed to try and promote good discharges, the summary of admission. So the GREAT stands for, the G is the GSF, R the resuscitation, E the whether there's a respect document, whether there's any advanced care planning, and whether there's a treatment escalation plan. And so that now is incorporated into our electronic record. Next slide, please. So what we did when the trust moved to an electronic patient record, we developed a document that could be completed. So obviously with all the implementation, there was lots of education, lots of support we gave as a specialist palliative care team to the wards. And we developed this document because of the engagement we had. It was felt that when we moved to the electronic record that the wards wanted this as well. So it's just a document where they can tick whether they've identified the patient as red, amber, green or not applicable. If they've identified them as amber or green, there's then a tick box to say, have you offered an advanced care plan? If they tick that they're GSF red, there's then a prompt box about using priorities for care, and then there's a preferred place of care that can be recorded. Next slide, please. So I just show this so you can see how it will look on the EPR. So each ward has got a tracking board, and you can see a GSF column on the far right. And this will show, there will be the colour, whether it's red, amber or green. The little house means that they've documented whether the preferred place of care has been decided, and obviously people can go back into this document and change it. And the useful thing as well, the bottom part of the diagram then shows a GSF amber with a little document with an exclamation mark, and that will be flashing in real life. And what that indicates is the patient was previously identified as GSF amber, and on their readmission, that's flashing and is a prompt for the team to review that. Next slide, please. So from using the electronic record, we can then produce monthly data around the percentage of our adult inpatients who've been identified as GSF. We then can look and say what percentage of deaths within the trust had been identified as GSF amber or red, and then the achievement of preferred place of care on discharge or death in hospital. We are working with our data analysts, and obviously this will need to be a bigger piece of work within Dudley Place to try and see if we can actually record achievement of preferred place of death for people who've been discharged from the hospital. We've set ourselves targets, obviously, because we know 30% at any one time are in the last year of life. And what we've done is to continue to support the wards and for that evidence so they know the targets they're looking at. We've repeated that each year, and it's been 30% each year, except for obviously 2020 when we repeated it during the initial COVID, and it was 40%. So you can see at the moment we're achieving about 16% of patients being identified as GSF red, amber or green. And we're at between 60 and 70% of hospital deaths being identified as GSF amber or red, and preferred place of care is around 60%. Next slide, please. And this is a busy slide, and it's just to show you how we can work with the ward. So I've just listed the number of wards there. But in that snapshot we did, so this is the last one we did in 2022, it will say how many adult inpatients were on that ward that day, and then how many have died in the following year in any setting. And as you can guess, a number of the wards, be it elderly care, critical care, the oncology ward, respiratory, GI, have got a higher number of deaths. But it allows the wards then to look at their evidence and gives them a target. And because we repeat it each year, that also gives them the assurance. And then the next slide, please. And then also what we do, so this is looking from April 22 to March 23, so another year. What we've looked at is the total number of deaths on each of those wards. And then we can look at the percentage identified as GSF amber or red. And again, we can, obviously those wards with a higher number of deaths, which are your respiratory wards, again, the ones I've mentioned. It means it helps us as a specialist palliative care team as well, focus those on where we direct the support we need to give. Yeah, so next slide, please. So obviously we started the implementation, the whole hospital implementation of GSF in 2019. And we've been very fortunate through all the hard work of the wards that we've got 9 ward areas GSF accredited that are listed there. CCU, critical care and rapid response, are the first in the country to achieve accreditation. The rapid response team is our community end-of-life team, and they were very keen to, on the back of the work we were doing in the trust, to work with us to gain accreditation. And this year, I mean, I've listed the wards, but C5 is a respiratory ward who we're working with, and they're going through the process of accreditation. And C6 is a urology ward. Next slide, please. So it's there has been, and at the end I'll talk about the culture change, but there really has been a culture change in the hospital through the identification of these patients. But it's not just about the data is one thing, and it's there for reassurance, but it's very much about that individual plan of care for patients and those important to them and what's important for them and their preferences. And it really has changed what we offer as a trust with the end of life care and legacy work. But what we need to make sure we do is this is joined up into Dudley. So what, again, with the GREAT acronym we developed, I've just shown you an example of how important that can be. If we've had some really good conversations in hospital, we need to make sure that's communicated out to our community teams and GPs. And obviously, similar to how Julie's mentioned, the GPs, the GSF is good because it's a common language across Dudley, and they obviously have their regular end-of-life meetings, and then we can hopefully carry on those conversations in community. Next slide, please. We've got for assurance, obviously, the NACIL, the National Audit of Care at the End of Life, and these were the results we got for the 22-23. And I'll just highlight that when we did the case note review, 90% of those cases we reviewed had evidence of an individual plan of care. And the other thing that I think is amazing is the staff survey. Obviously, we're repeating this year the NACIL, but the staff survey is that, you know, it was nearly 90% across the 3 domains that were asked, that they felt that they feel they have the skills and they feel they work in a trust that prioritises care, compassionate end-of-life care. So I think that was, again, assurance around the importance of implementing the gold standards framework. Next slide, please. What we've also found as a specialist palliative care team, and you know, the theme today has been about the inequalities, and there's a number, and you've mentioned about non-cancers, and we know that often specialist palliative care teams, most of the referrals that we have are cancer patients. What we've found through implementing the gold standards framework is that there's been an increase in our referrals, but that's good. And you can say, well, actually, is that people are just referring to, you know, what's changed is that actually we're getting the more complex ones that we should be getting, and there's that identification of the unmet need. And before, whereas teams, if I give you an example of coronary care, it'd be if they identify somebody, it's let's get the specialist palliative care team involved. Now they only get us involved if it is complex, because they take, and what's changed is the language being used in that this is our responsibility as a team to do. This is important, this is core business. So although our referrals have gone up, what this slide demonstrates is that we're almost, we are 50-50 referrals for cancer and non-cancer. And as we know, there's lots of evidence out there that patients with non-cancer have just as poor as prognosis, just as many complex symptom control needs. But hopefully we're showing how this is actually improving that access to specialist palliative care. And the other thing we found is that it's developing such good working relationships that we're developing other MDTs. So we know there's cancer MDTs that we attend, but we've established a joint liver MDT with our GI colleagues. We're working with a community heart failure team, and also with a respiratory team to look at doing joining an MDT about hospital avoidance. Next slide, please. And this is just an example. These are some feedback, just some quotes that we've got, and an example of how, you know, before it would be that the specialist palliative care team would need to get involved if we wanted to do something to provide that individual care. But it's just amazing, and it's so good that I can go on a ward and they'll have arranged a wedding, that they arrange for a horse to come to the back of the hospital. Pets are regularly being brought in. An afternoon tea with somebody wanted to do. A doctor recently, this lady loved her nails and she wanted a manicure. And so as part of the legacy work, we do remembrance photography and different things. So there has been a massive culture change that is a joy to see, to be honest, for the improvement of an individual plan of care. And I'll leave it at that. Thank you.
Hi, Joe. There was one specific question that has popped up in the chat box, and it's from Jackie Tudor, and she's saying, how are you sharing patient preferences and the GSF patient information with primary care, your community services, and care homes on discharge? So how does that information get sent?
It's all through that. It should be on that summary of the summary of admission. So we're working very hard to try and make that the main focus of, that's how the information is going to be transferred, because if the patient's been identified as GSF, red, amber or green in the trust, on the summary of admission, there's a tick box when they complete it that they then tick that they've been identified as GSF amber or green or red. And then what we're trying to do is improve because if good communication has been had, we haven't got a EPAC system set up yet in Dudley, but that is, I know within the ICB that is coming, and that will make it a lot easier then. So the summary is the main form of communication out, but obviously through working with our community teams, you know, the rapid response team, the heart failure team, respiratory team, we can have that improved communication if there's complex patients that we need to communicate out to.
Thank you.
There was another question that came up about the benefit of advanced care planning, and which is always a very good question. I'm part of a thing called Advanced Care Planning International, and they do biannual conferences. It's very interesting to see how advanced care planning is interpreted differently across the globe, and some countries have invested in a national advanced care planning lead. Unfortunately, as Julie said, ours hasn't nationalised this or got a central platform for this, although there has been lots of national work, but really valuable to demonstrate some of the evidence and that's published on the ACPI website, and I and others wrote the UK summary of advanced care planning down the years in the UK, that there is evidence of some things of preference. But I think the question of does this make a difference and in what way and how can we measure it locally is always a valuable question. Wouldn't you say, Julie Barker, when you've done that? It's very hard to say that dying in the preferred place of choice is always the whole thing. Of course, that isn't the whole thing, but decreasing ED admissions, decreasing hospital admissions are tangible measures of progress, as Muir mentioned in the first talk, aren't they?
Yeah, I think, as you say, Kerry, there's very clear evidence that just having had advanced care planning conversations makes a difference. And certainly we've demonstrated that clearly over the last few years with the trends in Nottinghamshire. Looking at the detail of what goes into advanced care plans was what I was particularly interested in my audit, and that shows again clearly what we would expect intuitively, that if you have a really well written advanced care plan that makes it very clear what a person's priorities are and how that translates to where they want to be, how they feel about hospitals, what you do if you need extra help, if your condition's changing, that your default isn't just to ring 999 or 111, then that makes a big difference. People know what they want to do and they feel empowered by it. And actually, EMAS, our local ambulance service, have been really helpful in helping us develop guidance for our frontline staff on how we complete the treatment escalation part of an advanced care plan. We use Respect in Nottingham. And we've done a lot of work on trying to get the quality of our Respect forms increased with some training to back that up.
Julie, just interestingly though, Cathy Mansfield, she said, you know, just a question, obviously just continue on there with ACP, and she's, you know, she's saying there as a system, they're pleased to advise that, you know, they're prioritising end of life care, which is brilliant to hear, brilliant, Cathy. But she says that she's mindful just by increasing the numbers of ACPs we have, and I suppose picking up on your point there, the quality of the advanced care plan is one thing, isn't it? But increasing the numbers of ACPs we have, it doesn't necessarily change the outcome for the person, potentially leading to poor experience due to expectations raised.
Yes, and I think that's an interesting one, because expectations have to be realistic, don't they?
Yeah.
And I think it comes down to not just having a tick boxy kind of conversation, but a conversation that really scratches beneath the surface. So if you've got someone who lives on their own, who has dementia, and you're having an advanced care planning conversation with a family, we all know that caring for someone with dementia at home as it progresses, depending on how it progresses, can be really challenging. So I don't know, I think you've just got to be realistic about how you have the conversation, and how you guide people as to the best kind of support that can be offered in your area for their particular situation, because everybody's different, everybody has different issues they're dealing with, and might feel very differently about it. One of my very first patients, who I looked after as a GP, had advanced heart failure, lived on her own in a remote rural village, but she was absolutely adamant that she would not go to hospital under any circumstances. So several years ago, later rather, when she had her dense stroke and was semi-conscious, we had a challenge on as to how to meet her requests, but actually her carers rose to the challenge because they'd been part of doing her advanced care plan. And they said, okay, we'll make it happen. Ambulance team contacted them and she stayed where she was.
Yeah, so I think building on from that, Julie, because what Kathy said there, so how can we provide confidence in our health and social care teams to use the ACP? Do you know what I mean, isn't it? It's acknowledging that it's there and actually, you know, working, you know, taking on board what the patient wants, isn't it? Just having that confidence, I think, for professionals to seek it out.
Yeah.
Rather than just being conveyed to hospital. This is what she was saying. People are conveyed to hospital with the ACP. Do you know what I mean? So
I think there's something
got a hand up, so we'll bring.
Oh, sorry. If I just add in,
yes, it's Kathy. Yes.
Yeah. Can I just add in from the international perspective, when they've done lots of work on this, that there's some of the early research was an ACP done at all, which is one question, and that's what we're questioning. But then on a personal qualitative individual, we will probably all know examples where it's really changed things. But in America, they developed this phrase that I found very helpful: goal concordant care. So with realistic conversations following on from advanced care planning discussions, it's the next step. When the family have completed advanced care planning, has the goal of the patient been fulfilled? So goal concordant care is another way of looking at, does it make a difference? And of course, there will always be examples when crises happen and something some unexpected thing can ensue. So I think there's lots of talk about how we measure benefits, but personally and then system-wise with goal concordant care, it can be quite good. There was also another question from Mark coming. Kathy, would you like to say a bit about what?
Yeah.
That's fine, because there's other questions in the chat, but that's been really, really helpful. And thanks, Kerry, for the other link about the American work. I'll look into that. Thank you.
Okay.
I had a very interesting question from Mark Hazelwood about getting your head round. Maybe it was what Muir said about health span and lifespan. Muir, I think you're still there. I wondered whether. So Mark says about. Is it possible to preventative strategies? It's to do with how people live well before they die. And this definition of end of life care we put as a year, at least that's progress from what it was before. It isn't really a definite year. I think last years of life is thing, but that health span and lifespan. Muir, would you like to say anything about that? You're still on muted. I know that Muir's done a lot of work of living longer, better.
Yeah,
it's not 70 in the books that you've written on this.
Yes, usually when we speak about healthy life expectancy and the period of life at the end of life, it really is not so much the last year of life, but being unable to do important things like get to toilet in time, or do the simple basics of life without being dependent on others. And that can last for years for many people. And we now know that can be is caused by dementia, by frailty, by disability. And we know that these problems now can be prevented, delayed, or even reversed. So it's the way I've worked with GSF is I'm interested in sort of the last decade of life and thinking about life in your 90s, because the expectation of life at 60 is 30. So you should assume you're going to reach 90, and then start to think, well, what's it going to be like in the 80s? So from 60 on, preferably earlier, but from 60 on, start to take action to compress that period where you're no longer dependent on others. So you're no longer dependent on others for simple tasks like getting the toilet on time. Then for all of us, of course, there will be, at the end of that, a period where it's obvious that dying is near. And I agree, I think it's very good that GSF has taken the last year of life, because it does look as though in the last year of life, people are deterioration accelerates. But there's no sharp distinction between these two. So let's increase health life expectancy. And part of that is remembering, as well as promoting prevention, we want to enable people to die well as live well.
And a lot of your work, Muir, has been about the living well until you die and then dying well, hasn't it?
Yes.
Mark, I just wonder whether you know about the 3 trajectories of illness that Joanne Lynn developed, which was just trying to quantify some of it. But also Chris Witt is really, many things that he said in his November report last year, but the emphasis on multimorbidity being not the same as frailty, but a predominant issue, and therefore the way medically we should respond is different. So don't send patients to different parts of the hospital for different sub-organs. We have to be more holistic. One of his big recommendations was affirming the generalist skills of doctors, and with the Coalition of Healthcare Frontline Care, we're trying to affirm the role of generalists, and that's what GSF does, of course. So keeping in mind the whole person, we're entering a new era where instead of thinking of people dying of accident, infection and childbirth and cancer and other things as specific conditions, most people are dying of multimorbidity, or the majority of the population, of age-related conditions, of dementia, obviously the biggest killer, frailty and multimorbidity as well. So as we move that way, pivot that way as a population, as a nation, how does our health and social care respond is our question, and that's what we're trying to look at in the coalition. There was another question directly to Jo Bowen about identification. I'd like also to say, Jo, one of the wonderful things I know about the work that you did, that these were the generalists on the wards identifying patients, weren't they? There wasn't a fancy tool. It was them instinctively using PIG. Can you say a bit more about that, about difficulty identifying patients at the end of life? How did Dudley move to GSF embedded in acute trust, available to GP systems and beyond?
Yeah, I mean, yeah, it very much was through those initial, we did, I think, nearly a year, didn't we, of workshops, I think 6 workshops over the year, but in between we did a lot of support, talking about the concept of the gold standards framework, about identification, but not just about identifying for the sake of it, that actually then it needs to mean something for the patient and those important to them. So there was, we did lots of presentations at lots of different audit meetings, at board rounds, at different things, but very much using the evidence as well, because I think you have to so doctors like the evidence side of things. So as long as you can show them the papers, the evidence, and the fact that we did all those snapshot reviews, the number of deaths, they can then understand the concept. So, and then we started with 3 proactive wards. You can guess one of them was elderly care. One was coronary care, so we had a very interested consultant. I'm trying to think of which the other one was. can't remember now, but there was 3 really interested wards, and because they actually set up, with the help of data analysts, a separate system to be able to record gold standards framework. That very much then, when we moved to an electronic patient record, it was one of the first things that we got moved onto that system, because it was being asked for by our working colleagues. But as Kerry says, this is the generalists identifying, and we are doing a piece of work at the moment to look at that identification and are they identifying the right people, and the initial results are very good as well.
And I think that's where things have got to shift, and that's a lovely example, Jo.
Just an encouragement to use the ACP Day in your sort of social media, public awareness campaigns. It's an opportunity for us to launch more public awareness events. If we empower our community to say what matters to them, it's going to make frontline staff job a whole lot easier when we're wanting to have advanced care planning conversations. That question there was posed by, so it doesn't tell us who posed it. Do you think specialist palliative care teams sometimes de-skill generalist staff? Oh, interesting. Almost like they don't need to do this.
I think that's one of the things that certainly with this coalition thinking that there can be a sense of de-skilling, and that's definitely what we're trying to reverse, upskilling generalist staff, because especially with age-related conditions, most care given for most people nearing the end of life is given by generalist frontline staff. So, and I know this
There's
is
a risk, isn't
there? I emphasize in my talk that in a system, a population-based system for living longer better, education is a key function. Education of other professionals is a key function. And it's the same for dermatology or respiratory medicine, whatever. The specialists will never see all the people in need.
I loved what Jo said about what the specialist palliative care team are seeing at Dudley, that they were the complex non-cancer patients. And I think that is just a great example of where, you know, really holistic patient care together with advanced care planning and patient identification is really powerful. Because some of our multi-morbid non-cancer patients are very, very complex, and to have a specialist palliative care view on it, unless you've got a very confident, highly skilled clinician looking after them in the community, is incredibly valuable. So but it's about getting our patients to the right people at the right time, isn't it?
ICS offer, really, it's just to make people aware, like you've heard there from Jo, you know, commissioning a provider organisation. So it may well be that you want to sort of look towards help and support for your recruit trust, like what Jo's already been able to demonstrate. But also, you know, PCNs, your care homes, domiciliary care agencies, retirement villages, or indeed your prisons. The other support offer would be end-of-life care roadshows. We're doing some awareness raising events across one of the ICSs. We're starting in June. Julie and I will be doing them in June. Also bespoke training tailored to the ICS needs and requirements. So this is about, you know, what you identifying what your gaps are, and actually how then can we best support you. And then what we're hoping to offer, and is certainly within the development, which we're all really quite excited about from a GSF point of view, is ICS accreditation. So we'd really value your views and thoughts about whether that's something you would be interested in. But they're the 4 support offers, you know, that are available to you. So yeah, if interested, do be in touch.
Muir, from the work that we've done many years ago of your values-based work, and you did that work in North East Essex of helping ICSs to focus on values in end-of-life care in the way that you describe.
Yes, yes. It's I think the key thing for the future is to look at populations, whether it's a primary care network or a place-based partnership or the catchment population of a hospice or the ICS, and we've got representatives of all these with us today. But I think what we will do, Kerry and I and Julia, We'll summarise the objectives for discussion and put that out. I think, Kerry, as one of the notes from this meeting, because the objective should be the same in Wales, in England, in Italy. It's a standard set of objectives, but how those objectives are achieved, the military say you take into account local history, geography, and politics. So service organisation is a network that's local, but we should have the same set of objectives.
This is something, this whole talk has sort of focused on the whole population-based approach to end of life care. And if anyone is particularly interested in being part of this and forming or contributing to our thinking on this, because we've all got to move on, we've all got to expand to population-based thinking, it's really essential to do. Please contact us well.
Just a thank you for coming. Hopefully you found it helpful, stimulating, challenging and useful. There's a couple of links on the slide which will be coming into the chat just with our evaluation survey. It would be lovely if you could complete that because it will help us develop future events effectively. And if there's a separate one specifically for interest in GSF programmes. A plea to everyone to take one or two things back to your areas, talk to your colleagues, have a think about what are the key things that you would like to do as a result of what you've heard this morning. And a few of you have kindly put in some responses of things that you're going to be doing, which is absolutely brilliant. Lots about sharing and feeding back, which is lovely to see. Yeah, brilliant. Thank you so much.
Thank you very much for everyone who's contributed and for your lovely comments in the chat and everyone who's taken part, particularly to Muir and Joe and Julie's contribution from Nottinghamshire. And we say goodbye. Thank you very much, everyone, for joining us.